Hello, my name is Anthony Cavallaro, and today is Wednesday, October 13th, 2021, and this is my answer to the Case Connections 2 unit assignment. Today I will be attempting to explain the reasonings behind cases 2 and cases 4, so let's start with case 2. Case 2 talks about a patient with a deficiency in muscle glycogen phosphorylase. She poses 4 questions pertaining to normal muscle glycogen function, meaning what does it look like for a person that isn't necessarily restricted by this deficiency, about exercise level, especially on a non-strenuous walk, a long non-strenuous walk with her friends, blood glucose levels, so she wants to know if she should be checking her blood glucose levels every night and also eating in the middle of the night to keep her blood glucose levels going, and lactate production to help her better understand her condition. Firstly, the patient needs to understand that muscle glycogen is an important factor in regards to exercise, especially strenuous activity. As the patient's body goes into anaerobic respiration, or a shift from using oxygen as an ATP source to using glycogen storage as an ATP source, one must be able to provide energy in another way, which is where muscle glycogen comes into play. Muscle glycogen acts as an energy source to help compensate the energy depletion from the lack of oxygen in one's system, meaning that when oxygen is not present, muscle glycogen is converted into ATP in order to provide that energy needed. However, there are some drawbacks to anaerobic respiration, such as cramping, due to lactic acid and other things. Concerning her walk, the patient shouldn't have to worry as much about long walks with friends, as the activity isn't as strenuous as going on a 3-mile run. For example, going on a long walk is more or less a leisurely activity. Yes, you are exerting yourself a little bit more. You may end up going into anaerobic respiration. However, it may not be the case because of the fact that it is normally a leisurely walk. Whereas in a 3-mile run, you're sweating, you are using a lot more energy, and you are losing a lot of oxygen and not taking in a lot of oxygen. They should be wary of the potential implications of strenuous activity with a deficiency of muscle glycogen phosphorylase, because there are a few symptoms that could lead to discomfort for the patient, such as cramps, muscle pains, and weaknesses in general, which could end up negatively affecting the rest of their day due to their metabolism's inability to break down glycogen. This is also called myocardial disease, and the patient should be cognizant of the lasting damage in muscles after long bouts of activity. Also, along with this, something that I found out is that the patient should be aware of tissue decay and the release of myoglobin, because that could lead to kidney failure, which could be potentially damaging to the patient in the long term. Concerning her worries about eating at night, she doesn't necessarily need to eat at night to maintain her blood glucose levels. Instead, the patient should monitor her daily diet, making sure that she eats a low carb and high protein, or something like a keto diet, taking supplements, and eating and drinking an excess amount of sugars before exercising if she chooses to do so, to help compensate for their low levels of glycogen. This may help her be able to generate some more ATP, producing the second wind, which is a concept very well known to this deficiency, which will allow them to exercise more freely. However, the drawbacks may still be present with muscle and tissue degradation, cramping, and overall fatigue after exercising. Lastly, the patient should not worry about producing excess lactate, as it has been found that lactate production is similar in both healthy and unhealthy individuals. The difference is where the lactate is produced, as those with a deficiency tend to have more lactate production in active muscles due to the fact that the lactate produced in patients is from blood glucose, whereas in healthy individuals is derived from glycogenolysis. So I hope this helped you understand the implications of muscle glycogen and the potential damaging effects of a patient deficient in it. We will move on to case 4 now, where case 4 talks about a 2-month-old female patient with jittery spells, long sleeping times between feeding, low blood glucose levels, and an increase in blood lactate when administered epinephrine. It is important to understand the role of epinephrine as well when concerning glucose and lactate, as that was a big factor for myself to be able to diagnose her. To get started, I just wanted to kind of go through the 3 diseases and deficiencies that this infant did not have. So for the first one, the patient did not exhibit the warning signs for hereditary fructose intolerance based on the information above. A few of the main symptoms include for this intolerance includes jaundice, vomiting, and growth defects, which the infant did not have. Along with this, there are typically increased levels of fructose in the blood, whereas the patient had increased levels of blood lactate. Although this is a life-threatening diagnosis in infants, it is not the diagnosis of this patient. This patient also does not exhibit the warning signs of galactosemia, a disease which disrupts the body's ability to make galactose, which is a major factor in many different signaling pathways and metabolic pathways. And a couple of the major warning signs of galactosemia are cataracts, which don't seem to be present within the patient, along with intellectual defects and swollen livers. Swollen livers obviously kind of does tie in with this infant. However, based on the other symptoms, I don't believe that this infant would have galactosemia. So there are no intellectual defects present within the patient. Other than the initial symptoms, the infant seems fine. Lastly, there are no feeding difficulties. Rather, the infant has a problem with sleeping too much in between feeding. It doesn't say anything about her being unable to feed. So before we get into the actual diagnosis, the patient does not exhibit the warning signs of glucose 6-phosphate dehydrogenase deficiencies as well. Symptoms aren't normally present within this deficiency unless their red blood cells are exposed to some sort of stressor, whether it be environmental, bacterial, or viral. The patient also doesn't exhibit any signs of anemia, which is a major drawback of having glucose 6-phosphate dehydrogenase deficiency because of the fact that the red blood cells kind of become that sickle-celled look, so that crescent shape rather than ovular shape. She also doesn't have shortness of breath or an enlarged spleen, rather she has a swollen liver. This deficiency is a primary cause in the reduction of blood cells leading to anemia, whereas the patient seems to exhibit some sort of glucose breakdown deficiency. That being said, I propose that the patient be diagnosed with glycogen storage disease, or GSD. The infant shows some signs of the disease, such as being around the age of 3 months, where it says she's 2 months old, but it says that this disease is typically diagnosed between the ages of 2 and 3, and she also potentially has an enlarged liver. This paired with her hypoglycemia makes glycogen storage disease a best fit for diagnosis. The jiggering of the infant may also be an indication of muscle weakness due to the fact that her body cannot fully break down glycogen. The administration of epinephrine is also a good indicator to help support this diagnosis. Epinephrine is a hormone, and it actually stimulates glycogenolysis and glyconeogenesis, which are two important factors in the glucose pathway, especially when it comes to blood glucose levels, because it actually increases blood glucose levels for a time. However, as we know, blood glucose levels were actually very low in this infant when administered epinephrine, whereas blood lactose levels or lactate levels upon administration of epinephrine were high, because this kind of shows that the infant is unable to break down glycogen regularly and as normally as other infants and as other people. So I hope that really helps you understand the diagnosis for case 4, and I hope that my case 2 helped you kind of understand the basics of the whole thing. Overall, I just want to say thank you for listening. I had a really fun time being able to kind of step into the shoes of a doctor and of a physician and of someone that will be diagnosing these diseases and rare genetic disorders. And it taught me a lot about having to kind of break down the process and understand the overall concepts. And if you have any questions, please feel free to email me or refer to the reference pages at the end of this manuscript. I hope you have a great rest of your day. Thank you so much.